All right, we're going to look at the gastroenterological system and alterations that are included within that system. First up, we're going to take a look at cleft palate and lip, and this can be two different as well as combined, basically related to the degree of deformity that is present. So you can have a full thickness defect of the lip and or palate, and it is due to failure of those facial prominences to fuse during embryological development. So normally what happens when we are developing the area is it does develop from all four sides, and that's what gives us the complete fusion of all those areas. So what happens in embryonic development is something happens that creates a hole in that situation so they don't fuse correctly. This is a very common craniofacial abnormality, and it is the fourth most common birth defect that we see in children. So it's likely multifactorial, and they do believe that risk factors include maternal smoking and alcohol intake. Also, certain meds would be associated with, such as phenytoin or retinoic acid, which we know is very tetranogenic. And you can see here that cleft palate is approximately 1 in 2,000 and does affect females more than male. But you can see cleft lip is quite more prevalent, and it does affect 1 in 1,000, but we see a shift from male to female. When we see this, there's also associated issues with nasal deformities and varying nasal problems that arise depending on the degree of the lip or palate deformity. Other things to consider is potential folate issues, as this would come up with nutritional deficits and not taking a multivitamin or a prenatal vitamin, as they have been shown to show protection against the development of cleft palate or lip. Surgery is usually the way that we cure it, depending on the severity of it. Need extensive versus not as extensive surgery. Squamous cell carcinoma, so this is a malignant carcinoma, and it usually involves the lining of the oral mucosa. Floor of the mouth is the most common area. Again, tobacco and alcohol would be your strongest risk factors. Other things would be betel nut and chewing tobacco. You would also classify this likely as an oral laryngeal cancer, and it is strongly associated with those alcohol and tobacco. So HPV infection has also been linked as a potential causative agent, and that would be associated with HPV-16. And you can see there that those tumors have increased and infects younger patients, so presenting in age 40 to 60 years. The HPV-associated oropharyngeal tumors would mainly affect the tonsillar carcinoma, and then to the lesser extent the base of the tongue carcinoma. Again, with HPV, the more sexual partners that you have, regardless if we're looking at cervical cancer or squamous cell carcinoma, it increases the risk of any HPV-associated carcinoma. If something happens that the patients do present with the oral leukoplakia or erythroplakia, then referral to ENT so that they could be diagnosed, and hopefully we don't have any spread. So the classic signs and symptoms would be some oral pain, systemically if we would see weight loss, sore throat, neck lump, especially related to some neck lymphadenopathy. And then what you're going to see are some type of indurated or ulcerated mass within the oral mucosa, usually under the tongue is usually where it presents. And then this is oral leukoplakia, that is leukoplakia, so this would be a white. If this was a red plaque, we would call that erythroplakia. So they may also have some otalgia, which would be ear pain, trismus, which would be jaw pain. Those would be the high yield findings. Your differentials for this would be a tonsillitis, aphthous ulcer, or oral syphilis would be high on your suspicion list. Treatment would be either surgery or radiation, depending on what stage the patient presents in, and then obviously if we have any local advanced disease or metastasis. Next up is mumps. So this is a viral infection that results in bilateral inflamed parotid glands. So this is kind of that classic look here. And then the parotitis, misvaccination, or failure would be what would lead you to a high yield situation and suspicion of this diagnosis. Orchitis, pancreatitis, and aseptic meningitis may be present and may cause a sequela of complications that could be quite detrimental for the patient. So this is caused by the paromyxovirus, which is an RNA virus that is spread by respiratory droplets. And the incubation phase is pretty long, about 14 to 18 days. And then viral replication happens, and it usually is within the epithelium of the upper respiratory tract. And then it spreads local lymph tissue, and that has that affinity for that glandular epithelium. And then what results is the local inflammation, and we get interstitial edema, painful swelling of the gland. So prior to us having vaccination, which is going to be the way that we prevent this, so that's that measles, mumps, and rubella. Prior to that, it most affected 5 to 9-year-olds. In the post-vaccine era, though, most mumps occur in adolescence and college age. Again, the important is this sequela of pretty significant complications, and that is why mumps is still taken quite seriously. So siladenitis is an inflammation of the salivary glands, usually the parotid or submandibular, so you're going to see it classically present in these areas. And etiology could be bacterial, or it could be related to an obstructing stone, which we call a salilith. There's also an autoimmune presentation or a sclerosing presentation. So what happens with these is it is an inflammatory and enlargement of one or several of those major salivary glands. And then the bacterial infection can cause a salivary flow, which is diminished. And this may be secondary to illness or medications or obstruction. And then Staph aureus is the most common bacteria. It can be intermittently painless, and it is unilateral or bilateral. And then there's no accompanying signs of infection. It also may be idiopathic, and that is due to an underlying condition such as ductal stenosis or autoimmune disease. Sclerosing siladenitis is a painless unilateral swelling that can mimic a tumor. So here is some pain, fever, dysphagia, pus exudate at the gland opening. So for the bacterial, it would be accumulation of the bacteria, inflammatory response, and formation of a microabscess, and acidic necrosis would be present. If it's chronic or autoimmune, varying degrees of inflammation and related possibly to that obstruction of the salivary glands by the salilith. We do get some T-cell infiltration, and then we get a acini destruction. Airway compromise would be something to be aware of. Obviously ABCs, and we're dealing with in the throat area. All right, we're going to move on down the esophagus into the lower esophageal area, which we're going to talk about the hiatal hernia. So the hiatal hernia is usually asymptomatic, but may present with some heartburn, dysphagia, otophagia, hoarseness, asthma, shortness of breath. So what happens with this is that we have a protrusion into the intra-abdominal contacts into the intrathoracic cavity. I have a picture coming up here for you. So we do have a couple types, but this would be the normal stomach and normal diaphragm. Here's your lower esophageal sphincter. So what happens here is their diaphragmatic hernia would be protrusion of the upper part of the stomach up through the diaphragm and into the thorax. We have two main types, one called a sliding, the other one called a paraesophageal. So here would be the normal, here's your diaphragm, stomach, esophagus. Here would be a sliding hiatal hernia, and that does mean that it can move up and down. If we have a paraesophageal hiatal hernia, it kind of creates that pouch above and it doesn't move back and forth. The sliding hiatal hernia is the most common type. And then the less common is the paraesophageal, which creates that sac that contains the herniated contents are contained within that sac above. So sliding hiatal hernia is the displacement of the gastroesophageal junction above the diaphragm, and it decreases the lower esophageal pressure. So because the lower esophageal is the primary determinant of the anti-reflux valve, a decrease in this pressure predisposes the patient to GERD. And then when we talk about the paraesophageal hernia, it differs in the fact that there is rotation, twisting of that stomach as it migrates into the chest, and that can produce intermittent strangulation with obstruction and ischemia. So your classic symptomology would include bowel sounds that you can hear in the chest, heartburn, dysphagia, some regurgitation, odonphagia, chest pain, shortness of breath, wheezing. Obesity would be a risk factor. Oropharyngitis may present, fevers, chills, and cough would definitely be in here as well, because one of the big things with GERD is a cough. How would we diagnose? Chest x-ray, upper GI series, EGD, CT, or esophageal manometry and pH monitoring. So with the chest x-ray, you are looking for a retrocardiac air bubble or being normal. Your upper GI series would include a contrast barium esophagram, and looking for the stomach is either partially or completely intrathoracic. Your EGD would be looking for inflammation of the esophagus and then proximal migration. CT MRI, again, looking for locality and also the degree of the herniation and intra-abdominal organs into the chest. Your esophageal manometry and pH monitoring would be looking for a double hump, how significant the hiatal hernia is, then confirming abnormal pH monitoring, which is seen in large hiatal hernias, and then that would need evaluate the need for anti-reflux surgery. Next up is the Mallory-Weiss tear or syndrome. So this is a longitudinal laceration at the mucosa of the gastroesophageal junction. This is usually related to a presentation with hematemesis after there is a forceful or recurrent retching, vomiting, coughing, or straining. It is usually related to severe alcoholism or bulimia, and it is regarded as a painful hematesis. This accounts for about 3 to 15% of all cases of an upper GI bleed. The way that we would diagnose this is from an esophagastroduodenoscopy, and we are going to be looking at if these tears are present. So the way that this happens is there is a sudden rise in abdominal or transmural pressure gradient, and that would be from the severe vomiting, from the retching, from coughing or straining, and that then across the gastroesophageal junction forces are high enough to cause distension in this area, which is normally a very poorly distended area, meaning it does not accommodate that situation very well. And then that results in these tears in the gastroesophageal junction area. The hallmark presentation is painful hematoemesis. Depending on how bad the bleeding is, then you could see postural or orthostatic hypotension, and of course lightheadedness or dizziness related to the decrease in BP and volume. Risk factors are any condition that predisposes to retching, vomiting, or straining, chronic cough, hiatal hernia, complications when they're getting endoscopy or instrumentation, significant alcohol use, and a history of previous instrumentation that may have left some tears. As you can see here, really any event would include food poisoning, gastroenteritis, anything that obstructs the GI tract, hepatitis, gallstones, to name a few, trauma, seizures, bulimia, cyclic vomiting syndrome. So really anything that could affect that area, the lower. For alcohol, while we do say there is a big proponent with this, we do see about 40 to 80% of patients having a history of severe alcoholism. So when we would be working this up, of course, you would get a CBC to see the degree of anemia, You would look at kidney function, LFTs, what are your clotting times, chest x-ray, and then of course we would be going to an EGD. When we look at the other thing that would present as hematoemesis, then we would be talking about esophageal varices. The main way that you would differentiate Mallory-Weiss versus esophageal is that it is painful versus painless. So with esophageal varices, we get painless hematoemesis. This is secondary to dilated submucosal veins that are present in the lower esophagus, and this is related to portal hypertension and cirrhosis. What we have are distended esophageal veins in that distal area that normally drain into the portal vein via the left gastric vein. We have evidence of portal hypertension usually, and that left gastric vein backs up and results in dilatation of the esophageal area, and that creates these varices. The most common cause of death in patients with advanced cirrhosis is esophageal varices. This is a progressive complication of cirrhosis and portal hypertension. So main causes here. So these are usually asymptomatic, or they may be found on other imaging. They would present with an acute bleed situation. So the highest risk of hemorrhage occurs in patients with large varices, and the important predictor of hemorrhage would be the Child-Pugh score endoscope finding of red Wally marks. So another way that you would find this is screening for any of your patients that have cirrhosis. The red Wally signs are basically the red marks that you would see when you do the EGD, and relates to the number of strands, the diameter, where the location is. All right, so the way that you would take a look at this is obviously if there is advanced liver disease or cirrhosis, and then you're really looking at what are those liver signs. So ascites, jaundice, spider angiomas, caput medusa, hematoemesis, hermatochezia, and encephalopathy. So obviously if your patients do have severe advanced liver disease or cirrhosis, then there would be a high propensity for them to have esophageal varices. So then also looking for any other etiologies that may put them at risk. So obviously CBC, CMP, LFTs, and coags because of bleeding risk, serology to rule out Hep B and C, and then your EGD is going to be the most accurate way to diagnose. Esophageal malformations, so these are usually congenital. They are a very common variant in the proximal and distal that arise from the trachea, and I have some pictures here for you to see what they are. So classified as esophageal atresia or transesophageal fistulas. They are defective differentiation that happens with embryonic development within the 4th to 6th week, and it is defective growth of the endodermal cells that lead to atresia, and then there is again incomplete fusion of those walls of the foregut, and then there's incomplete closure of the layer in laryngotracheal tube and fistula formation. Here you can see a couple different types. Here is atresia with distal fistula. Here is an isolated esophageal atresia, and then a double fistula. Here is an isolated H-type. Achalasia, so this is a disorder of esophageal motility with the inability of the lower esophageal sphincter to relax. And this is secondary to damaged ganglion cells in the myenteric plexus. So remember back in A&P, we had those various layers of where the nerve endings are. Myenteric plexus is one of those levels. So the damage may be caused by Chagas disease, which is by the Trypanosoma cruzi microorganism, or it can be idiopathic. And what happens is we have damage to the ganglion cells, which causes an inability to relax that esophageal sphincter. Other things could be autoimmune, which are rare causes. So classic features of this would include dysphagia for both solids and liquids. You could have a putrid breath, and we mean putrid. This would lead to the bird beak sign on a barium swallow. So what this is significant dilation of the esophagus with a smooth distal narrowing and tapering, which is that bird beak sign and is classic characteristic for achalasia. Next up is something that very common and present in many of the population. So GERD, which is gastroesophageal reflux disease, and this is where we have reflux of the acid from the stomach up into the esophagus due to relaxed or reduced lower esophageal tone. So risk factors do include alcohol, tobacco, obesity, fatty diet, caffeine, and hiatal hernia. So how this happens is we have a normal resting tone. So we have our lower esophageal. We have a zone of high pressure that prevents reflux. And what happens in GERD is that this pressure is lower, and either from transient relaxation or weakness of the sphincter, vomiting, coughing, bending, or obesity can increase that pressure, and then it causes reflux. So there also can be contributions from delayed gastric emptying, which contributes to a reflux gastritis. So gastritis severity is based on a couple items, such as composition of what is in the stomach, the length of time that they are in contact with the esophageal mucosa, and what is the epithelial resistance to the acid. So the classic symptomology of this, of course, is going to be heartburn, acid regurgitation. You can have some voice change as well as some swallowing difficulties, bloating and early satiety, and then some bad breath going on. Diagnostics for this are actually you just give a PPI for 8 weeks. So something like Protonics, and see how things are at 8 weeks. And then if they are not better, then you can go to more specific testing, such as an EGD, ambulatory pH testing, and esophageal manometry. Complications of this can then lead to our next discussion, which would be Barrett's esophagus. And this is due to the fact that we have a lot of reflux going on and we get that dysplastic change. So remember back in the beginning of our lectures where we talked about metaplasia, dysplasia, and how things happen to lead us to a potential for cancer development. So metaplasia of the lower esophageal mucosa from stratified squamous epithelia to non-ciliated columnar with goblet cells. So the lower portion of our gut is well made to deal with high acid, right? So we have columnar epithelium with goblet cells, bring on the acid. We have ways to protect ourselves. The stratified squamous, which is up here above the lower esophageal sphincter, is not equipped. So then we get some changes and we get metaplasia regurgitated. So we go from a stratified squamous epithelium to a columnar epithelium to combat all the acid that's coming up. So we have metaplasia, then potentially dysplasia, and then adenocarcinoma. So GERD is the number one etiology and increases the risk. Tobacco use, obesity is another. So this presents in a classic middle-aged white man, and they have had a history of GERD. Other things would be tobacco use and obesity. Okay, so let's just take a quick look at esophageal carcinoma. So we have a couple different types. We have adenocarcinoma. We have squamous cell carcinoma. So adeno, remember, is going to be related to glands, right? So adenocarcinoma is going to be a glandular carcinoma. If we have squamous cell, then it's going to be related to the squamous cell layers. So with the adenocarcinoma, we have malignant proliferation of the glands, most common type of esophageal cancer. And this is your pre-existing Barrett's esophagus, which is going to be the lower 1/3 of the esophagus. When we talk about squamous cell, we're talking about malignant proliferation of squamous cells, This is the most common esophageal cancer worldwide. And then we're talking about the upper and middle 1/3: alcohol, tobacco, very hot drinks, achalasia, and certain injuries predispose the patient. So location of lymph nodes spread will give you high yield points of where the location of the carcinoma is. So if it's in the upper 1/3 of the cervical, then we're talking, more related to probably a squamous cell. If we're talking about middle third, which is mediastinal or tracheobronchial, still potentially could be the squamous cell. When we get to the lower 1/3, we would be looking at the gastric and celiac lymph nodes, and then you would be looking at your adenocarcinoma. Unfortunately, it presents late, and there is usually a poor prognosis associated with both of them. Gastrochesis, so these are congenital malformations. We're going to talk about gastrochesis and omphalocelli. Just remember that they both are protrusions of abdominal contents outside the wall. The difference is whether there is a sac or not a sac. So in gastrochesis, no sac covering the intestines, and they are basically exposed. This is related to some risk factors that include a young maternal age and some issues with an elevated alpha fetoprotein. There is a problem in utero where there is a thick inflammatory film or peel overlying the intestine, and it causes a delay of the return to the normal bowel function after closure. When we look at omphalocelli, this is persistent herniation of the bowel into the umbilical cord, and then you do have that sac covering it. So the contents are covered by the peritoneum and amnion of the umbilical cord. So this is related to older maternal age, and then also potential fetal-chromosomal abnormalities, and would be indicated and detected on a prenatal ultrasound. Pyloric stenosis, this is a congenital hypertrophy of the pyloric smooth muscle. So what happens is we have increased hypertrophy and hyperplasia of the circular sphincter that is around the muscle pylorus, and it ends up being grossly enlarged. So you can see here is what it looks like. The opening is very narrow, and then what happens is there's encroaching muscle that increases peristalsis, and the force of the gastric contents through the narrow opening increases. So this is associated with that recurrent projectile non-bilious vomiting. So this is high yield projectile non-bilious vomiting. And then there's also visible peristalsis on the child's abdomen, and you will find an olive-like mass in the abdomen, which is related to the hypertrophy and hyperplasia of the sphincter. This does typically present within 2 weeks, but up to 6 weeks. After birth, usually happens in the male population more than the female. Main things that would arise would be feeding intolerance, multiple formula changes, failure to thrive, weight loss, depletion, things like that. So you will see it firstborn infant, non-bilious projectile vomiting, definitely postprandial, which means after meal or after food. 3 to 6 week old, abdominal mass, peristaltic waves. So etiology is unknown. They do have some theories about it. So they think that there might be hyperacidity that is the result of antral distension, and with that also possibly poor pyloric muscle neuronal innervation, and then potentially maybe a lack of pacemaker cells, and that would obviously be your intestinal pacemaker cells. Nitric oxide deficiency has been indicated as well, but they really don't know. These are just really kind of theories and potential causes that they have associated with it. Risk factors that they believe happen is the presence of prematurity, early exposure to erythromycin, prostaglandins, maternal exposure to macrolides, and then there is a geographic and ethnic background situation. Location, Western populations, Western heritage is 4 times more likely to develop than in the Chinese or Eastern cultures and ethnicity. So they do believe that there is a hereditary situation. So because firstborn infant here, and definitely male firstborn infant is the strongest epidemiological factor, and it's 4 times greater in male infants than in female infants, and it usually affects that firstborn male infant. Moving on to acute gastritis. So this is acidic damage to the mucosa of the stomach, and it is basically an imbalance of your protective parts of the GI system versus an insult, whether it's infectious, irritant, or some other cause. You do have acute versus chronic gastritis, and we're going to go into both of them. So remember what we talked about back in the review of anatomy and physiology. We have that mucin layer, which is produced by the alveolar cells. We get bicarb secretion. We have surface epithelia, and a normal blood supply. Provide nutrients, take away acid. What happens is we get a superficial inflammation, we get erosions, and we ultimately can get an ulcer. H. pylori is one of the most common, in addition to use of NSAIDs. Alcohol also increases your risk. And then stress, which would be, remember that we have a whole bunch of serotonin receptors, as well as our gut has very large nervous response, right? We have a lot of nerve endings in our gut. So your classic presentation and symptomology would be a dyspepsia, an epigastric discomfort, and acute abdominal pain. You can have severe nausea, vomiting, and loss of appetite, altered reflexes and sensory deficits, cognitive impairment, and glossitis. Always be aware of a coexisting autoimmune disease. Remember, one autoimmune disease begets another autoimmune disease, and that would be that more rare etiology. So diagnostics, we would do an H. pylori, so you could do a fecal antigen test or a H. pylori breath test. CBC, make sure there is no evidence of any infection, and then ultimately you would end up with endoscopy. So chronic gastritis is chronic inflammation of the stomach lining, and this can be autoimmune or chronic H. pylori infections. The autoimmunity is related to autoimmune destruction of those parietal cells that line the fundus and the stomach. Then we have antibodies against those parietal cells or intrinsic factor, and then it's mediated by a T cell infiltration, and we have a type 4 hypersensitivity. So what happens is there's atrophy of those mucosa cells with intestinal hyperplasia, achlorhydria with increased gastrin levels, and antral cell hyperplasia. You can get a megaloblastic anemia due to lack of intrinsic factor, and there is an increased risk of gastric adenocarcinoma related with chronic gastritis. Various strains of H. pylori exhibit difference in virulence factors, and these influence the outcome of H. pylori infections. So a lot of times there may be some that are difficult to eradicate, and then that's when you get into the chronic gastritis. Moving on to peptic ulcer disease. So this can either be a duodenum or stomach ulcer. So you get a solitary mucosal ulcer that involves either the proximal duodenum or the distal stomach. So we'll take a look at both of these. So the duodenal ulcer is related to H. pylori and 95% of the time, rarely due to Zollinger-Ellison disease. And your presentation would include epigastric pain that improves with eating meals. Ulcers are hypertrophy of the Brunner glands, and they arise in the anterior duodenum. When we talk about a gastric ulcer, we are talking about H. pylori in 75% of those again. Others would be peptic ulcer, steroids, bile reflux. So this is epigastric pain that worsened with meals. And then the ulcer is usually located at the lesser curvature of the antrum. So it's going to be down in here. So you can see here the gastric ulcer would be here, and here is your duodenal ulcer. Here would be an esophageal ulcer. So they do extend through the muscularis mucosa. So it goes down through pretty many layers of remember that we have those multiple layers within the gut system. And usually those layers are impermeable to acid and pepsin, but once the integrity is altered, then its ability of the protective layer to not protect anymore. So risk factors, H. pylori infection, known or not known, and then drugs, lifestyle factors, stress is another big one. Genetics also plays a role in it. The drugs, of course, would be NSAIDs are the big ones. Steroids also are high risk for destroying the peptic layer. All right, gastric carcinoma. Just be aware of that. This is a malignant proliferation of the surface epithelial cells, so it would be an adenocarcinoma, intestinal or diffuse types. This usually presents with a late presentation with weight loss, abdominal pain, anemia, and early satiety. As you can see, we have our multiple layers of the GI tract. So we have that surface epithelium, we have our basement membrane. Remember, it is localized until we penetrate the basement membrane. Here we have the lamina propria, muscularis, submucosa, muscularis propria, and then we have periesophageal tissue. So what happens is, as it's still mucosal, it has not gone through the basement membrane, but once we get to T2, T3, T4, you can see how it has reached those layers and are now potentially near lymph nodes, and then will create a higher stage of presentation. Intussusception, so this is that telescoping of the proximal segment of the bowel forward into a distal segment associated with a leading edge, which is called the focus of traction. It is usually in the ileocecal location, does have a common age of presentation, so about 3 to 12 months, with peak at 9 months. It does affect males greater than females. It can occur in older children and adults, but usually has a pathologic lead point. What does that mean? It means there is something going on that causes the reason for the intussusception, such as a mass or a tumor. Infants will present with fever, lethargy, vomiting. They will get waves of colicky abdominal pain and flexing of those legs up. What happens is there's abnormal peristalsis, the bowel wall edema, and hyperplasia of Peyer's patches, and lymphoid tissue is present. That causes the telescoping of the intestinal lumen due to that hyperplasia. It is likely related to an antecedent viral infection, but it also can have no known cause, and we label it as idiopathic. We're going to spend a little time with celiac disease, as this has been growing in the number of people that are manifesting it. So celiac disease is an autoimmune process, and it results in damage of the small bowel due to the villi related to a gluten. It is associated with the genes HLA, DQ2, and DQ8. So gluten is present in many things, wheat, grains, and the most pathogenic form is gliadin. So what happens is we have the autoimmune process, so we're going to end up with loss of tolerance to the peptide antigens. Once absorbed, gliadin then is deaminated by the tissue transglutaminase, which is TTG. This is what we're going to test for. And then that's presented as an antigen to the major histocompatibility complex. Helper T cells will mediate damage to the tissues. Flattened villi on biopsy. So we get hyperplasia of the crypts and increased intraepithelial lymphocytes. So here is the normal brush border and the villi that is present on our duodenum. So what happens in celiac disease is basically those T cells attack it and basically break it down, and we have that flattening. of the villi. Classic signs are diarrhea, bloating, abdominal pain, and discomfort, especially after eating anything with gluten. One of the first things that you would do is do a food restrictive situation for the patient to see if we can take out all gluten and see what happens. Weight loss fatigue because they're not absorbing, nutritional deficiency again because they're not absorbing, anemia because you're going to have problems absorbing your vitamins and iron. You can get a dermatitis herpetiformis, and you would also have immunoglobulin A deficiency, IgA deficiency. Its presentation is quite varied, meaning it can be mild to quite severe. And then there's also iron deficiency anemia, osteoporosis, again, because you do not end up absorbing most of your vitamins. So CBC with smear, because you're going to be looking for your anemias. IgA-TTG is that transglutamase, and that's what we're going to be. That's pathonomic. That's what we would pull for diagnosing the celiac disease. EMA is endomysial antibody. That's another way that we can take a look at it. You could also end up doing skin biopsy when they go in with endoscopy for small bowel endoscopy or histology at that time. Quickly, just a couple of the intolerances. Just basically lactose intolerance is some people have no problems with it, some do. Maybe congenital, another autosomal something, or acquired or temporary. All depends what's going on. But normally we can digest lactose, gets turned into glucose and galactose. If you're lactose intolerant, you do not have lactase, you get bacterial fermentation, and then we get acid and gas and end up with irritation and some discomfort. All right, acute appendicitis. So remember, we have that little dude down there. Really don't know what exactly it's for, but it likes to become inflamed and infected. So obstruction of the appendix is usually by lymphoid hyperplasia in children, a fecal lith in adults, and effective or normal stew. So some foreign body ends up basically plugging the hole, and we get anything, we get an infection and inflammation behind it. It is a clinical diagnosis. We do have a couple signs that are very important. And these are your diagnostic features. So the Rovsing sign, which is you press on the left and the pain is on the right lower quadrant. Psoas sign is you extend that right thigh, elicits pain in the right lower quadrant. And then you have right lower quadrant tenderness, which is called McBurney sign. You would also order CBC, acute abdominal series, pelvic CT, pregnancy test in the appropriate population. Usually presents in adolescence or early adulthood, nausea, vomiting, fever. Another sign is the obturator sign, and that is pain elicited by internal rexation of the right flexed thigh. Fetor is an abnormal odor. Basically, it's like a sick smell. So people smell like they're sick, and that's what fetor is. Hirschsprung, this is a defective relaxation and peristalsis of the rectum and distal sigmoid colon. So it's going to be working down here, and it is congenital failure of the ganglion cells to descend into that myenteric and submucosal plexus. So that's why it's very to remember those layers in your GI system, because there's a lot of stuff that is pathologic with those layers. Rectal suction biopsy lacks the ganglion cells, and then it's commonly diagnosed in the first year of life. Abdominal distension, vomiting or colitis, foul-smelling stools with explosive passage, delayed meconium passage, and then failure to thrive. Diverticular disease, take a look at that. That is those little outpotchings of mucosa and submucosa through the muculosus muscularis propria, and that's related to wall stress associated with those low fiber diets, constipation, and risk increases with age. There's a lot of people that have diverticular disease. Does not necessarily mean they will get diverticulitis. All right, with IBS, understand the brain-gut situation. So irritable bowel syndrome is a lot of times related to stress, and also some of the central pain issues. So there are a lot of stress and psychological comorbidities. There is no identifiable pathologic changes, and that's why we really put a lot of emphasis on stress and psychological comorbidities. So there's altered gut motility and disturbed secretion in response to many stimuli, which may be environmental, certain foods, overgrowth of toxins, many, many things. So you can see here everything that's playing into the potential of either constipation or diarrhea based, or it can be mixed. So you can have one, two, or both. Colonic polyps, just be aware of that. We take a look at these when we do our colonoscopies. They are raised protrusions of the colonic mucosa. Most common types are hyperplastic and adenomous changes. So if we end up getting concerned for adenoma or carcinoma, just remember that we would cut these out to make sure that they don't keep growing. All right, so we have issues when we get them pretty large, greater than 2 centimeters, if there's sessile growth and their histology comes back as villous. There's another what it looks like when they're kind of growing here. So it arises from the colonic and rectum mucosa. It is the third most common cancer. In fact, they just changed the screening from 50 down to 45. So we are seeing a lot more population. All right, so colorectal cancer, colonic polyps are why we do the colonoscopy to catch them before they arise into an adenoma or carcinoma. So carcinoma of the colorectal area is the third most common cancer, and it is the third most cause of cancer-related deaths. So adenoma or carcinoma sequence and microsatellite instability. So what happens is we get a hyperproliferation. We have small or large polyps. This is usually where we go in and cut them out. And then we can have severe dysplasia, which would have some abnormal cell growth, which would be evident when we do a histological evaluation after the polyp is removed. And then it would progress into a adenocarcinoma. And again, once it breaks through the basement membrane, we consider it invasive carcinoma. All right, we're going to spend a little bit of time with inflammatory bowel disease, as this does present in both children and adults, and this is a very unfortunate situation and a lifelong issue. So we have two types of inflammatory bowel disease. We have ulcerative colitis or Crohn's disease. They are both inflammatory bowel diseases. They possibly related to abnormal immune response to the enteric flora. It does classically present in young women as recurrent bouts of bloody diarrhea and abdominal pain. It is a diagnosis of exclusion after you roll out multiple other things. So we're going to take a look at ulcerative colitis first. So this is an inflammatory bowel disease, affects the rectum and extends proximally. So rectum and extends proximately. So it's going to go up. And then it's diffuse inflammation, and there is colonic mucosa of a relapsing and remitting course. So it's not all the time you get waves of it. It is multifactorial polygenic disease. Do not know exactly why it happens. And they basically, because it's autoimmune, state that you have an environmental trigger and a genetic susceptibility. Again, with these is the highest incident rates are those in the northern and western hemispheres, and the lowest incident is Asia and Far East. So again, very interesting with geographic locations here with some of these autoimmune. So classic presentation for ulcerative colitis is the bloody diarrhea. chronic diarrhea, lower abdominal pain, fecal urgency, and then we can have extraintestinal manifestations, and those are related to erythema nodosum and acute arthropathy. Erythema nodosum are areas on the shins that are raised bumps and they're painful. Arthropathy basically means that you're going to have some joint pain. So what happens is you have inflammation of the crypts of Lieberkahn, and then you have abscesses. The ulcerated areas are soon covered by granulation tissue, and this creates an undermining of the mucosa, and excesses of granulation tissue form polypoidal mucosal excrescences. These are known as inflammatory polyps or pseudopolyps. Diagnosis does require endoscopy with biopsy and then negative stool culture to rule out any other situations that may cause the bloody diarrhea. Toxic megacolon can be associated with risk of perforation. Bowel adenocarcinoma is a complication in about 3 to 5% of the patients. When we look at Crohn's disease, this is inflammatory bowel disease of the entire gastrointestinal tract, so from mouth to anus and anywhere in between. Multiple etiologies include infectious, immunologic, environmental, dietary, psychosocial. Hallmark of this is that we have skip lesions, and these are transmural inflammatory areas that will lead to fibrosis, and then they could potentially cause an intestinal obstruction. Classic presentations for this is chronic diarrhea, weight loss, and right lower abdominal pain that mimics an acute API. So here we have chronic transmural inflammation that thickens the bowel wall and leads to scarring, luminal narrowing, and stricture formation. This leads to fistulization, sinus tracts formation, perf, and abscess. This leads to malnutrition, dehydration, vitamin and nutrient deficiencies. It involves the terminal ileum, which it's going to interfere with bile acid absorption, which leads to steatorrhea, fat-soluble vitamin deficiency, and gallstone. So because it can affect anywhere on the GI tract, you will have a lot more issues with. So here's a nice little schematic to kind of compare Crohn's versus ulcerative. So as you can see here, the inflammation is not constant like it is in ulcerative colitis. Skip lesions means that it will skip an area and go to another area. And that's where we get the varying degrees of issues versus the proximal from the rectum all the way up the sigmoid into the descent with the exocrine, pancreas, liver, and gallbladder. So pancreatitis will be first up. You can have acute versus chronic. It is inflammation and hemorrhage of the pancreas. It is basically auto-digestion of the pancreatic parenchyma, and it results in both a liquefactive hemorrhagic and fat necrosis. So we have two types of necrosis. Remember that the pancreas has a fat layer on the outside of it. That's how we get fat necrosis. The coagulative liquefactive is the interior, related to the autodigestion from pancreatic enzymes. So this will give that classic epigastric pain with radiation into the back. It's almost like you're being stabbed through the abdomen, nausea, vomiting, periumbilical pain, and flank hemorrhage. And that means the necrosis has spread into the periumbilical soft tissues and retroperitoneal. Most common causes: gallstones, alcohol, if there is an alcohol history, high calcium levels, trauma, hypertriglyceridemia, drugs, mumps, duodenal ulcer, rupture, and scorpion sting are the other etiologies. The difference is chronic pancreatitis is often a state from recurrent acute pancreatitis, which then results in the fibrosis of the pancreatic parenchyma. Again, alcohol is a big one here, and cystic fibrosis for children. Same abdominal pain, but also get steatorrhea and soluble vitamin deficiencies due to the fact that you do not have your enzymes being released appropriately. Your enzymes will not help in diagnosing this. And when it looks, if you grab a CT, it looks like a chain of lakes pattern in the pancreas due to dilatation of the pancreatic ducts due to the dystrophic calcification. You also can get a secondary diabetes due to the destruction of the islet cells with chronic pancreatitis. Also increases the risk of pancreatic cancer. Gallstones, technical name is cholelithiasis, and this is gallstone formation with the secretion of bile that becomes supersaturated with cholesterol from the liver. What happens is these stones will obstruct that cystic and or bile ducts. There can be transient obstructions, and those are those acute and waves of attacks, and then there can be a more persistent obstruction, and then that's going to lead to an acute cholecystitis presentation. Uncommonly, a large gallstone becomes impacted in the cystic duct, compresses the common bile duct, and causes obstruction and jaundice, but that is uncommon. The transient obstruction is going to result in that biliary pain, and that's what we would get with these transient attacks. So the gallstones are related to precipitation of cholesterol and bilirubin. And here you can see a picture of what it's going to look like. Here would be an obstructing stone down here. Otherwise, they just sit in there. They arise from three kind of different methods, whether there's a supersaturation of cholesterol or bilirubin, or there's decreased phospholipids or bile acids, or there is cholestasis, meaning nothing's moving. The risk factors that are included is older age. Risk factors that are included are female gender, pregnancy, obesity. Rapid weight loss is actually a very common cause. So a whole bunch of quick weight loss, and then also a family history. All right, we do have acute versus chronic. Acute cholecystitis may resolve after symptom onset. If cystic duct patency is not reestablished, then we could potentially have necrosis. Inflammation of the gallbladder or the gallbladder wall helps mediate an inflammatory response with PGI2 and PGE2. Those impacted stones will close the cystic duct. Symptoms are relieved when the duct opens and the stone passes. Classically, we'll have right upper quadrant pain with radiation into the right scapula. Risk of rupture if left untreated. Moving on to the liver. So just have all of the signs and symptoms of liver disease. So be aware that all of this is high yield, and you should know it because this is how you're going to detect liver disease. Here is also pictures of how it would be in a child versus an adult. So acute liver failure would be a rapid decline in hepatic function, and this would be jaundice, coagulopathy, hepatic encephalopathy. Everybody here is a nurse. We're all pretty good with being able to know when there's an acute liver failure. Remember that it is massive hepatocyte necrosis, and that's what's going to ultimately result in organ failure. Remember that the P450 system is there, and when we use chronic alcohol or barbiturates, we deplete. Remember, glutathione is something that decreases reactive oxygen species, so we are going to keep depleting that with chronic use. Acetaminophen overdose, intentional or unintentional, is the number one cause. Otherwise, we're looking at other drugs that cause it: acute hepatitis B, autoimmune hepatitis, shock, and hepatitis A. You can see there are still quite a large amount that remain undetermined. Again, remember what your signs are, everything that we just talked about. So with acute liver failure, just be aware that we then can progress if we continue to have problems related to cirrhosis. So when we look at liver fibrosis and liver failure, precipitating events are all listed here. Pre-cirrhotic disease is about 10 to 35 years out. Then we get into compensated cirrhosis for about 10 to 15 years. We can have acute on chronic liver failure. We would start to get acute decompensation, and then we're into the severe phases of decompensated cirrhosis. And that's when we're going to start seeing those classic signs and symptoms of liver disease. One of the big causes, of course, is hepatitis, general term referring to inflammation of the liver. Various causes, infectious versus non-infectious. Either clinical illness or histological findings associated with the disease will help you determine etiology. Adults with acute Hep A or B are usually symptomatic. Adults with acute Hep C can be symptomatic or asymptomatic. So when we talk about viral hepatitis, we do have 5 now classified, A, B, C, D, E. They are one of the most frequently reported diseases, and usually patients will present with fevers, abdominal pain, malaise, and jaundice. Common exam findings include hepatomegaly, clinical jaundice, and marked elevation of serum aminotransferases. When we talk about the capsule of the viral hepatitis, so depending on what you're looking for will tell us if we have a core antigen, a surface antigen, and that is related to your immune status versus whether you have an acute infection. So hepatitis B surface antigen, hepatitis core antigen, hepatitis E antigen will all help you with determining that. So when we measure serology related to hepatitis B, so that's the main one that we test for. So hepatitis B serology is the measure of the several different antigens and antibodies. So it's between being able to differentiate between an infection that is acute versus chronic, or the possibility of immunity from vaccination or a previously cleared infection. So how do you interpret HBV serology is a crucial skill that you need to be able to develop. So here is a nice slide for that. So here you can see the marker is the hepatitis B core antibody. Here is the hepatitis B surface antigen. Here is the hepatitis surface antibody. All right, so just remember AB equals antibody, and then AG is antigen. So then you can see here acute, window, chronic, remote immunization, or an inactive chronic carrier. So when we look at the hepatitis core, so remember that the core is going to be this internal area, okay? So the core of the virus. So if that is positive, it means that you have an acute infection. In addition to hepatitis surface antigen, so basically think it's gone the whole way through, okay? So that means it's going to be an active acute infection. It does not confer immunity. So there is a window period, and that's what this is down here. So for the blue line is your hepatitis B core antibody. So if you get exposed, then you're going to have exposure to it, and it's going to stay positive for a long time. That core is going to be positive. So if you see here surface antigen, which means the acute infection does last for a couple days, and then it goes back down, and then that is considered the window period. And that means that the infection is not present at that time. So then hepatitis surface antibody means that you have immunity. So it would not mean that you have an acute infection. There's no window period. So you would not have chronic infection either. So the way that surface antibody would be present is if your body cleared an infection or you received an immunization to hepatitis B. So that is where you would see surface antibody positive. If you go back up to the surface antigen, window period negative, remote infection cleared negative, and the rest of them. So her hepatitis surface antigen will only be present in an acute infection and chronic infection. So it's indicating that there is an infection. What time that it is tested would be if you had the acute thing going on or a chronic. Core, again, the entire time that you are carrying and infected and exposed to the hepatitis B. Remember that hepatitis B is parenteral routes, blood, body fluids, sexual intercourse, whether vaginal or anal, blood-to-blood contact, IV use, needle stick injury, and then mother to infant via vertical transmission during pregnancy and delivery. So what's also important to know is the incubation period ranges from 45 to 200 days. So you can almost be latent for almost a year. The average time span is about 75 days. This is a clinically relevant period. There is a notable gap between the initial infection and the appearance of the HBV viral antigens and antibodies. Okay, so that's this lag time here before we can test the titers. With chronic infection, there's usually no physical signs, but that's where we get the liver disease and risk of hepatocellular carcinoma. There's another slide here, basically hepatitis A through E. You can see here there's still a large amount of cases worldwide per year, and 1.4 million people die from hepatitis every year. 90% of hepatitis C can be healed within 3 to 6 months, much better than where it was when it was first diagnosed for the baby boomers. And your baby boomer population usually gets screened for this. They haven't already. Remember, A and E is by fecal oral, and then B, C, and D is body fluids. Moving on to cirrhosis, this is diffuse hepatic fibrosis and conversion of the normal liver architecture to structurally abnormal nodules. Progression of liver injury to cirrhosis, and it may occur over weeks to years. Again, hepatitis is one of your most common, especially hepatitis C, alcoholic liver disease. Let's go for the combo, and then there can be some other causes. So what happens with the cirrhosis? We have a couple sequelae, and that's what we'll be talking about next. Portal hypertension. So that is an increase in that BP within the systems of veins within the portal venous system. So those veins coming from the stomach, intestine, spleen, and pancreas merge into that portal vein, branches into the smaller vessels, travels through the liver. So what happens? They get blocked during the liver damage. The blood cannot flow. We get increased pressure, and that leads to the development of large swollen veins, varices within the stomach, rectum, esophagus, and umbilical. Again, your common causes. And there is just a look at the portal vein and how everything goes into it. Then we get ascites, which is the accumulation, and it's a state of total body sodium and water excess. The event that initiates it remains unclear, but many pathogenic processes have been implicated. There are three theories: underfilling, overflow, and then peripheral arterial vasodilation. And then here is kind of that flow chart. Hepatic encephalopathy, hepatorenal syndrome. Please read these, as these are complications as well. Here's a nice flow chart for you to see what happens. Fatty liver. So this is one of those storage diseases that we talked about in the first class. Fatty liver, there is lipid accumulation. Remember, your cholesterol is metabolized and made in the liver. And we have a lipid accumulation. The liver actually looks greasy and yellow. And there are one or many mechanisms in motion. So increased free fatty acids, failure to convert to phospholipids and allows to convert to triglycerides, increased triglyceride synthesis, decreased apoproteins, failure of those lipids to bind with the apoproteins, failure to transport out of the cell, and then damage to the endoplasmic reticulum. As we know, that's the little packaging. So here is a nice picture of a fatty, greasy liver. We can get it from non-alcoholic, which is NASH. We can have the ability of both metabolic versus alcoholic that will lead to the cirrhosis. But pretty much fatty liver is not related to alcohol. And that's the new name, non-alcoholic fatty liver disease. And its main clinical picture is steatosis, liver cell injury, and that chicken wire fibrosis. They believe it's a two-hit phenomena, which is that we have an imbalance of fatty acid metabolism that leads to that hepatic triglyceride accumulation. And then the second hit is that we have oxidative and metabolic stress, dysregulated cytokine production, and unable to compensate for altered lipid homeostasis. Risk factors are all metabolic. So this would be a metabolic patient. Must take care of blood sugars. We must take care of obesity and cholesterol. And that's how we deal with improving the non-alcoholic fatty liver disease. So non-alcoholic fatty liver disease has a couple spectrum. So we have non-alcoholic fatty liver. We have non-alcoholic steatosis, which is NASH. And you can see there where the classification is. Neonatal jaundice. So understand what physiologic jaundice is versus the pathologic jaundice. So normally bilirubin production is elevated because there's increased breakdown of fetal erythrocytes. Result is shortened lifespan of fetal erythrocytes and higher erythrocyte mass in neonates. Hepatic excretory capacity is low because of low concentrations of binding proteins and because of low activity of glucuronol transferase, which is one of the enzymes responsible for binding bili to glucuronic acid, basically conjugating it. So physiologic jaundice appears within those first 24 hours, should be intensified by the 4th or 5th day, 7th day for preterms, and then it should not be clinically detectable after 14 days and should not need any type of treatment. When we talk about pathologic jaundice, also appears within 24 hours of age, but on the underside of that 24 hours, we have substantial increases in bilirubin, and then jaundice is going to persist for 14 days. Stool clay colored, white colored, urine staining, clothes yellow, and you're going to have issues with your direct bilirubin. The most likely etiologies of physiologic jaundice versus pathologic jaundice. So pathologic jaundice would be immune or non-immunic hemolytic anemias, maybe a polycythemia, biliary atresia. So this is characterized as the obliteration or of the extrahepatic biliary system, which results in a obstruction to the bile flow. So this disorder represents the most common surgically treatable cause of cholestasis in the newborn. It is a congenital malformation of the biliary duct. Signs and symptoms would usually be a varying degree of jaundice, dark urine, light stools. No pathonomic findings are present. However, you may experience an enlarged liver, spleen, direct hyperbilirubinemia, physiologic jaundice that frequently merges into conjugated hyperbilirubinemia, and the liver may be midline. Last but not least is Wilson disease. So this is a rare autosomal recessive related to copper metabolism issues. It is characterized by excessive deposition of copper in the liver, brain, and other tissues. It is often fatal if it's not recognized and treated when symptomatic. So there's 3 major patterns of hepatic involvement, to include chronic active hepatitis, cirrhosis, and fulminant hepatic failure. Classically, you will see Kaiser-Fleischer rings, and they are formed by the deposition of copper in the descemet membrane of the limbus of the cornea. So these nice lines here would be the Kaiser-Fleischer rings, and you can see it here on a blue-eyed person. So hepatic dysfunction is going to be the main presenting feature. So again, you need to know your hepatic signs and symptoms. Whether it is minor hepatic involvement versus fulminant would be what signs are present, such as ascites, spider nevi. So you would have to order, obviously, ceruloplasm. So remember, those metals must be transported. So ceruloplasmin is the carrier protein that carries copper. So these levels would be less than 20 milligrams per deciliter for most diagnosis of the Wilson disease. Your reference range is 20 to 40. And that is what we're going over for the GI system.